Hi everybody, thanks for joining us. I'm Julie Christensen, I'm an audiologist, and Dr. Jeffery Kim is a neuro-otologist. We work at the National Institute on Deafness and Other Communication Disorders at the National Institutes of Health, and we're going to talk to you today about our research in hearing and ear findings in Loeys-Dietz syndrome. We have no conflict of interest to report. Loeys-Dietz syndrome is a rare connective tissue disorder like Marfan syndrome, and initially people with LDS were mistaken for having Marfan syndrome, but it has its own distinct clinical findings, specifically widespread arterial aneurysms and tortuosity, hypertelorism or wide-spaced eyes, and cleft palate issues like bifid uvula. The pathogenesis of LDS involves a loss of function in the transforming growth factor or TGF-beta pathway, which results in a paradoxical upregulation of TGF-beta signaling. There are 6 LDS subgroups, and they're determined by mutations in the genes listed on the slide: TGF-beta receptor 1, TGF-beta receptor 2, SMAD3, TGF-beta 2, TGF-beta 3, and SMAD2, respectively. In this talk, we're going to discuss our findings and the implications for clinical management of otologic and audiologic findings in people with LDS. We enrolled 36 people in an observational natural history study. They were between the ages of 5 and 67, and you can see with the table the breakdown into LDS types. We saw people types 1 through 4. We didn't see types 5 and 6 solely because of the rarity of those types. The second column N is the number of people within each type, and then the sex and the average age and standard deviation. So some quick anatomy. The ear is seated in the temporal bone of the skull, and it divides into 3 sections. The outer ear, which is your pinna and ear canal, the middle ear, which starts at the eardrum and includes the space behind the eardrum, as well as the 3 little bones that called the ossicles that connect to the cochlea, and the cochlea, which is the inner ear and also includes the hearing nerve and the balance portion of the ear, the semicircular canals. When we test hearing, we do air and bone conduction. Air conduction is the one where you put headphones on and the sound travels through the air. It goes through your ear canal before it slams into your eardrum and vibrates those 3 little bones into your cochlea. Bone conduction is when we actually put a transducer behind your ear on your mastoid, and that vibrates sound right through your temporal bone, straight to your cochlea, and bypasses the external and middle ear. We graph hearing on an audiogram, and I'll show you at the top. Those are frequencies, low pitches to high. They're all the frequencies you need to hear to understand speech. Vowels are mostly in the low section and consonants in the high section. On the left is soft sounds to loud sounds in decibels, and the green area is the normal range. Circles are the right ear and X's are the left, and these marks measure the softest sounds a person can hear at each of those pitches. Now, the green section are very soft sounds, and speech is louder than that. And so some people call this a speech banana, but it shows you in general where conversational speech falls on the audiogram. So in the case of this person, they can hear the low frequency sounds really well because that's all here, but they're going to have more trouble hearing higher frequency sounds, which are predominantly consonants. We describe hearing in 2 ways, degree and type. Degree is shown here, and it's how loud a sound has to be before it can be heard, and can range from mild to moderate, moderately severe, severe, all the way to profound. The other way we describe hearing is by type, and there are 3 types. One is a conductive hearing loss, which is where there's a middle ear pathology that prevents softer sounds from reaching the inner ear or cochlea and hearing nerve. On an audiogram, it looks like this, where bone conduction is normal because it's vibrating straight to your normal hearing cochlea. But air conduction is not, and that's because the sound has to travel through that pathology in the middle ear that attenuates it before it reaches the cochlea. Sensorineural hearing loss is where the pathology is in the cochlea or 8th nerve. And on an audiogram, the bone and air conduction look the same. They lie right on top of each other. And the third type of hearing loss is a mixed hearing loss, where there's a pathology in both the middle and inner ear. And on an audiogram, it looks like this. There's a hearing loss through bone conduction because of the pathology in the cochlea, but then there's a worse hearing loss in air conduction because in addition to what's happening in the cochlea, the sound is also getting attenuated as it travels through the middle ear. In our group of 36 people with LDS, 62% had normal hearing and 38% had a hearing loss. This slide breaks down the degree of hearing loss by LDS type. And you can see that across all 4 types, the degree of hearing loss is limited to mild or moderate, with the exception of 1 ear in LDS type 1, where there was a severe hearing loss at just the highest frequency. For type of hearing loss, we also broke it up into LDS types 1 through 4. The green is normal hearing, yellow is conductive hearing loss, and the blue is sensorineural. Now the purple in LDS type 3 is unspecified, but was very likely sensorineural. What's interesting is that the conductive hearing loss was limited to LDS types 1 and 2, occurring in about 30% in both, while sensorineural hearing loss was limited to LDS types 3 and 4, occurring in 43% in LDS type 4, and if you include the unspecified, 60% in LDS type 3. Now I'll hand over the rest of the talk to Dr. Kim, who will talk to you about the otologic findings. Thank you.
Julie, thanks for going over normal ear anatomy and physiology as well as our hearing data. I would like to present ENT features that we found in our LDS patients. The most common feature was a facial asymmetry, followed by widely apart eye, also known as a hypertelorism. When we looked at one of the distinct hallmark LDS characteristics that distinguish it from Marfan syndrome, namely palate anomalies, the high arch palate was found in 81% and bifid uvula in 39%. Small number of our patients had surgery for soft or hard palate in the past, and most of the palate anomaly occurred in type 1 and 2. The palate deformity can result in eustachian tube problem. Eustachian tube, as shown in the blue arrow, is tube that connects the middle ear space to the back of the nose. Its dysfunction can lead to abnormal middle ear pressure causing recurrent ear infections. The recurrent and persistent ear infections are commonly treated by ear tube placement as shown here. Close to 1/3 of our patients had the ear infections requiring ear tube placement. Close to 50% of type 1 and 2 patients had a history of ear tube placement. On ear examination, tympanic membrane or eardrum perforation as shown here was found in 6 of 21 and 4 out of 26 ears in type 1 and 2 respectively. Once the ear tube comes out, typically eardrum hole closes by itself. However, sometimes it can lead to non-healing tympanic membrane perforation. It occurs in 60% and 40% of type 1 and 2 respectively in our patients. This rate is much higher than typical instance of tympanic membrane perforation of 15 to 20% in non-LDS patients with the cleft palate anomaly. Chronic tympanic membranation was a response for all conductive hearing loss in type 1 and 65% in type 2. In addition, chronic ear infection and eustachian tube dysfunction can create prolonged negative middle ear pressure and leads to a cholesteatoma, condition where squamous debris or wax abnormally accumulates in the middle ear space, as shown in this picture here. Typically, a surgery is required to treat this condition. In our study, one case of middle ear cholesteatoma was found in type 1 and 2 cases is in type 2. In type 3, cholesteatoma was found in ear canal. In conclusion, hearing loss is fairly common in LDS with an incidence of a 38%. LDS patient might be more prone to have ear infections and cholesteatoma due to eustachian tube dysfunction associated with the palate anomaly. Conductive hearing loss and tympanic membrane perforations were limited to type 1 and 2, whereas the sensorineural hearing loss was limited to type 3. Non-healing tympanic membrane perforation after ear tube placements were more common than expected. It is possible that TGF-beta pathway involving LDS might be preventing normal healing process of tympanic membrane perforation. Therefore, a decision to undergo ear tube placement should be carefully considered. If eardrum repairs are considered, perhaps using a sturdier grab like cartilage might be helpful to prevent a surgical failure. However, it's important to keep in mind that this observation is based on a very small number of LDS patients and more studies needed. Based on our study, we recommend comprehensive ENT and hearing evaluation for all patients with LDS and routine surveillance. Our finding was recently published in Audiology and Head and Neck Surgery Journal. I'd like to acknowledge the following people from NIDCD and NIAID who was involved in this study, especially Dr. Pamela Guerrero for leading the study at NIH. I also like to especially thank the patient with LDS and their family for participating in this study. Obviously, we couldn't have done the study without them. And also, I'd like to finally thank the Marfan Foundation for allowing us to present our study at this virtual meeting.